In the session. Okay, sir.
Yeah, sure. Please go.
Good evening and a warm welcome to all the dignitaries present here. I'm Ria from the Clarinet, serving as an allocated session assistant to ensure a seamless experience. Clarinet stands as India's most relied upon digital platform, offering a multitude of enriching services exclusively for doctors. It is with great pride that Clarinet serves as a digital partner for this event hosted by National Neonatology Forum. And the focus of today's session is NNF Shine Week 9 is June. So let's begin today's session, for which I would like to introduce Dr. Veera Raghavan sir. So without any further delay, I'm handing over the session to you, sir. Kindly proceed with your talk. Thank you so much, sir.
Thank you for your kind introduction. Everyone can see my slide, right? And I'm audible.
Yes, yes.
Okay. Today's session is on neonatal sepsis, a very important topic and something that has become a menace in our country. So millions of babies die of neonatal sepsis. And I request my postgraduate students who are attending this session to be very attentive. And if you have any doubts, please put it in the chat box. I'm not sure whether you have the option of raising your hands. So I'll start my session. So the learning objectives of this lecture are as follows. Initially, we will look at how to identify a neonate with sepsis. What are the signs and symptoms of neonatal sepsis? And then we'll move on to the etiopathogenesis. What are the most common organisms prevalent in tropical countries such as that of ours? Then we'll move on to the diagnostic aspects. And we'll concentrate a little bit on sepsis screen because it is one of the most abused investigations, as I would say. And finally, we will see what are the basics of management of a neonate who is diagnosed with sepsis. So, neonatal sepsis is defined in a different way when you compare it with the pediatric population or the adult population. In pediatric or adult population, you need to prove bacteremia to define sepsis. Whereas in newborns, even focal infections are categorized as sepsis. So the definition of neonatal sepsis is, it is a clinical syndrome characterized by signs and symptoms of infection with or without accompanying bacteremia in the first 28 days of life. So we have to be very clear. You need not have bacteria, might have bacteremia, but it is not a mandatory criteria. Even focal infections, such as that restricted to lungs, which is the most common organ that is affected, is also classified as neonatal sepsis. Now, traditionally, neonatal sepsis has been divided into two categories: early onset and late onset. So, early onset sepsis presents usually within the first 72 hours of life, and late onset sepsis presents after 72 hours of life. The traditional teaching is that the early onset sepsis is usually is obtained from the maternal genital tract, whereas the late onset sepsis is attributed to the care practices in the NICU and the organisms that have colonized the NICU or the environment surrounding that, or if the baby is in the discharged in and sent home, then it is occurred from the community. Now, coming to clinical presentation of both early as well as late neonatal sepsis, there is not that much of a difference. The spectrum is quite wide. The only difference is, the main difference is that the incidence of meningitis is quite high in late onset sepsis. and mode of transmission we already discussed. Now there are certain caveat to this slide. Now the traditional teaching was time of onset was within 72 hours. Now you have a separate category called very early onset sepsis, which is what we are seeing nowadays in India. The bacteria, I mean, usually it's bacterial sepsis that we talk about. You can have you have fungal sepsis and other types of sepsis. Even virus can also cause sepsis like syndrome. So very early onset sepsis is where the neonate is septic and it presents within the first 24 hours of life. And the second caveat that you have to clearly see in this slide is the source of organism. Now, previously it used to be, we used to say that it comes from the maternal genital tract. But because the incubation period of these virulent organisms are so short that if your delivery room practices or delivery room care is not up to the mark, the baby can acquire sepsis from the delivery room and present within 72 hours as well. So solely attributing sepsis to being acquired from maternal genital tract is something that we have evolved over a period of time. So, but the classic definitions are these. So when you are asked a question in your examination, this is what you are supposed to tell. Now, what are the risk factors for sepsis? Prematurity, of course, low birth weight, antepartum or intrapartum history of chorioamnitis. Please do go and read the new definition of chorioamnitis. The definition has been a little, it has been tweaked a little bit by the ACOG. Rupture of membranes for a prolonged period of time. 18 hours is what the Westerners say, because the group B streptococcus coccus used to be the most common organism there. Here some organizations do say that rupture of membranes for more than 24 hours as being a risk factor. So both of them you can take it as risk factors. Prolonged labor lasting for more than 24 hours. Foul smelling liquor, which actually comes under clinical chorioamnitis. A single unclean vaginal examination. For example, vaginal examination done by the eyes. These practices are now not that prevalent as it used to be decades back, or more than or equal to 3 sterile vaginal examinations. That is a very common thing that happens in most of the hospitals. Now, coming to late onset sepsis, multitude of reasons why baby might acquire sepsis from the surroundings. I'll specifically talk about the NICU. So when you see all these points, there are 5 bullet points. The most common reason is NICU understaffing and not adhering to hand washing protocols. Always remember, we have lots of bundles to prevent different types of sepsis. Every bundle starts with hand hygiene. So hand hygiene is the key component. Then there are other risk factors such as requirement of invasive procedures, poor skin integrity in extremely low gestational age newborns born at less than 28 weeks, frequent handling, unwarranted use of antibiotics. So these are other risk factors. The other pathogenesis that is quite often overlooked is nutrition. Nutrition plays a very important part in preventing sepsis, adequate nutrition. So early initiation of enteral feeding will translate to lesser period of the baby being on parenteral nutrition or intravenous fluids, and the use of mother's own milk. These are very important things that uh, can reduce the risk of neonatal late onset sepsis. So I am talking to you in a positive way. I am not telling that these are the risk factors. I am telling you how to prevent this. Now coming to symptoms. So as I told you in the initial slides, uh, neonatal sepsis can present with a myriad of symptoms, signs and symptoms. The usual symptomatology is lethargy, poor feeding, poor suck. Uh, Most common sign is respiratory distress. So these are the other things that I don't want to go into in detail. One thing I'll stress upon is this particular row suggestive of meningitis. So compared to pediatric population in newborns, you most likely wouldn't find uh, a sign or a symptom indicative of meningitis. That is the something that is peculiar to the newborn population. So meningitis has to be suspected in any baby uh, who is diagnosed with sepsis. So, what is the gold standard for diagnosing sepsis? Isolation of the microorganism from the supposed to be sterile fluids in the body, which includes blood, the CSF, urine, or if it is a localized infection, pus. In clinically suspected cases of sepsis, uh, always remember before starting antibiotics, blood culture has to be drawn. A single dose of antibiotics can affect the results of your blood culture. So as I said, it is the blood culture is the gold standard for diagnosis of neonatal sepsis. It is a mandatory investigation prior to starting antibiotic. And it also gives the sensitivity pattern if an organism is isolated. Remember, only 20% of I mean, septic newborns will have a blood culture that would grow some organism. The other part that I want to stress to the postgraduate students is that we should not go only by the sensitivity pattern that is given by the microbiologist, because that sensitivity is called what? In vitro sensitivity. Now the baby itself has got mechanism to defend against sepsis. So when you are treating a baby with antibiotics, it is both the antibiotics and the in vivo antibodies transferred from the mother and the other immune response that the baby's body mounts, they act together. So clinically, you have to see whether the baby is improving with the empirical antibiotics that you have started or not. If not, then switch on to the antibiotics that is given in the sinistogram and choose the one that is the least of the broad spectrum. That is the narrowest spectrum of the antibiotics has to be chosen. I hope I am clear. I don't want to confuse the first year postgraduate students. Tapas sir, please do intervene if I am going in depth into things.
Yes, yes, sure.
Now, sepsis screen. It's a very, as I told you, this is something very routinely done in all NICUs. So it's a combination of laboratory parameters, and you should know what is the utility of a sepsis screen and when it should be done. So perform sepsis screen in if early onset sepsis is suspected clinically, or the baby is completely asymptomatic but has got risk factors that makes the baby prone to develop early onset sepsis. The risk factors we already discussed. So what are the components of sepsis screen? The total leukocyte count, or the absolute neutrophil count, the immature to total neutrophil ratio, the micro ESR in the first hour, and the C-reactive protein. So if at least 2 out of these 5 parameters come as positive, then we call it as the sepsis screen being positive. Now, the problem here is in many centers, they don't do IT ratio, they do not do micro ESR. It's not because it's a complicated thing to do. It's only because people are lazy. So IT ratio has to be done by the resident. So as a first year postgraduate student, you should have a microscope in your NICU. If not, at least request your professors to get a microscope. Go to the microbiology department, learn how to count the immature and total leukocyte count and how to derive the IT ratio. And you should also know what immature neutrophils mean. What are the components of immature neutrophils? And micro ESR is very, I mean, it can be performed by anyone, but we do not do that. So we usually go by only total leukocyte count, the neutrophil count, and the CRP. So my message to all the postgraduate students is that please learn how to use the microscope to calculate the IT ratio, and please do micro ESR. That's not rocket science. So a fall of more than 15 millimeters in the first hour is significant for micro ESR, and a CRP of more than 10 milligram per liter is significant. And for leukocyte count, the cutoff is 5,000. And for absolute neutrophil count, the cutoff is 1,800. Compared to, again, we'll compare with the pediatric population. Why does neutropenia or leukopenia happen in the newborn population and not leukocytosis? Because if a newborn is septic, it does not mount a proper immune response when compared to pediatric population. What happens is that the bone marrow will get suppressed. That's why all these counts come down. But this is not uniformly true. In term babies, they can mount a response. But overall, this is the definition of sepsis screen. There are 5 parameters. If at least 2 are positive, then we call it as the screen being positive for sepsis. I want to concentrate on that second point. A neonate with positive sepsis screen may have an infection, or it could be a false positive result. Sepsis screen has got a very good negative predictive value. That is, you do 2 sepsis screens 24 hours apart and it comes negative. Then you can safely rule out infection. But the positive predictive value of sepsis screen is very low as around 20-25%. What does it mean? If the screen is positive, the neonate might or might not have an infection. I hope that is clear. Now, coming to lumbar puncture. So meningitis is something that can be overtreated, but it should not be missed because it can have serious consequences. In our practice, over a period of, say, more than a decade, we have seen many babies who were undertreated, not, I mean, diagnosed when they actually had meningitis. They come 2 to 3 weeks later with partially treated pyogenic meningitis with hydrocephalus, and then things are gone. whatever interventions you do, that baby will most likely end up with long-term neurodevelopmental issues. So the only scenario where a lumbar puncture is not indicated is if antibiotics have been solely started due to the presence of risk factor in an asymptomatic baby. So if the baby is symptomatic, if the baby is, you think that clinically baby is symptomatic, and you started antibiotic or sent the culture, yes, lumbar puncture is indicated, whether it is early onset sepsis or whether it is late onset sepsis. Now coming to management, in newborns, if anyone asks you a question, it starts with TABC. The most important aspect is what? Maintaining the temperature. Then airway, breathing, circulation. Ensure optimum oxygenation, maintain a saturation of 91 to 95. This is according to the American guidelines. The European guidelines will say 90 to 94. Maintain normoglycemia. Give a dose of vitamin K if it has not been given prior. And sepsis per se is not a contraindication for enteral feeding, but if the baby presents with abdominal signs and symptoms such as septic ileus, then you are justified in keeping the baby nil by mouth for some time. And remember, septic ileus responds rapidly to antibiotics. And the last thing is exchange transfusion, which is quite controversial. Many centers do that in cases of scleroderma. What is scleroderma? Scleroderma is a condition where the subcutaneous fat gets liquefied, and when you clinically examine the baby, you cannot pinch the skin. So these are caused by virulent organisms like Klebsiella, multi-drug, extensively drug, pan-drug resistant organisms like Klebsiella, and so and so. Now, when you start, I mean, which antibiotics you will start? The first line, second line, third line antibiotics would depend upon your unit. So the antibiogram has to be evaluated. Usually the time limit that they say is 6 months to 1 year. The past 6 months to 1 year, what all cultures you have sent, what are the pattern, what are the organisms that were isolated, for which organisms they were sensitive to, and then you also have to correlate it clinically, whether you use that particular antibiotic and treated the baby, or you continued with your first line and treated the baby, and how the baby responded. So both the clinical and the antibiogram has to be taken into consideration before you formulate your antibiotic policy. Now, empirical upgradation of antibiotics can be considered only in certain scenarios. For example, if the baby's clinical condition does not improve within 48 hours, or if the baby is critically ill, like baby has fluid refractory shock, then you are justified in upgrading the antibiotics. Remember, this is a fact published in a paper. 95% of the times, antibiotics are started because of the physician's fear of sepsis rather than the baby actually having sepsis. This does not apply to newborns alone. It applies to pediatric population as well as the adult population. And now, what is the role of CRP, serial CRP? There are various centers that do serial CRP monitoring. My message to you will be, you start antibiotics where you have a strong suspicion of sepsis, or the screen is positive or culture is positive. Just repeat one CRP 72 hours after initiation of antibiotics. If you see a downgoing trend, I'm not telling that it should normalize. Suppose the CRP was 80 and now it is 60. If you see a downgoing trend, just stop there. Don't keep on repeating. Fine. The duration of antibiotics will come in the, we'll talk about in the coming slides. Now, there are some conditions that traditionally used to, be treated with antibiotics prophylactically. The most common being a baby born through meconium stained amniotic fluid. Meconium is a sterile thing. So even in meconium aspiration syndrome also, there is no role for prophylactic antibiotics. The same clinical pathway you have to follow even in babies who are born through meconium stained amniotic fluid. Respiratory distress, it could be RDS most likely, it could be TTN, but there is one red flag sign in respiratory distress. Respiratory distress, which starts beyond 6 hours of life, always have a strong suspicion of early onset sepsis or congenital pneumonia. Perinatal asphyxia, and if you only have one or two risk factors, one risk factor, jaundice, prematurity, congenital heart disease, these are not indications for starting prophylactic antibiotics. Remember, my dear friends, we are already in a soup. It's, when I talk to people from other countries, they say you are in deep trouble. Yes, we are in deep trouble. The kind of organisms that have been isolated, sometimes even the microbiologist is not able to decipher what organism it is. Now, for cults, now we'll talk about the duration of antibiotics. Now, if the sepsis screen is positive, point number 2. Okay, if the sepsis screen is positive, the duration of antibiotics is usually 5 to 7 days. If the newborn gets, if this becomes asymptomatic, try to stop on day 5. Don't extend till day 7. Okay. Now, asymptomatic neonate who was started on antibiotics because he was at risk factor for early onset sepsis because of clinical chorioamnitis or prematurity, the risk factors that I outlined. Stop antibiotics if the 48-hour culture is sterile. Why we say 48 hours is because traditionally in India, we report 24-hour culture and 48-hour culture. So from what time point you should take that time? From what time point? Suppose in a clinical scenario, I'll tell you. You are on duty. A newborn is admitted at say 10 p.m. in the night. And you have drawn the blood culture. And the blood culture is sent to a lab. And the lab accepts the entry is done at 10 a.m. in the morning because it's not a emergency investigation, right? The microbiologist will report the 24-hour culture the next day 10 a.m. That 24-hour culture is not 24-hour culture. It is actually the 36-hour culture. So that is a very important point that you have to bear in mind. So from the time of inoculation, you have to calculate the hours. And if your 36-hour culture is sterile, then you can reasonably rule out sepsis. But because these have been going on since many decades, we always wait for the 48-hour culture. Even then, you count from the time when you inoculated into the Bactec bottle and don't refrigerate it. Keep it in room temperature. That is very important.
এতগুলো জল কেন নিয়েছিস? জলগুলো বেশি খাওয়া খাওয়া ঠিক হবে না?
Now, for culture positive sepsis, the duration of antibiotics is usually 10 to 14 days. If it is a gram-positive organism like, say, corns, you can stop it on day 10. If it is a gram-negative organism, we usually give till 14 days. And if meningitis is diagnosed, usually the treatment is for 21 days. Now, coming to antibiotic stewardship. Whichever conference you attend, there will be a topic on antibiotic stewardship, which is very important for our country. If you have time, go and read Get Smart with Antibiotics, the CDC, American recommendation. So you'll have a list of things that comes under antibiotic stewardship. We will point out only a couple of the important things. First thing is choosing the appropriate antibiotic and timely initiation of the therapy. And the second thing is optimization of the dose, route, and duration. As I said, duration, try to restrict it if the baby has become asymptomatic. If the baby is symptomatic, of course, you can go for till 7 days in sepsis screen positive, the example that I gave in the prior slide. And there are other aspects to antibiotic stewardship as well. I think that will be coming in the next slides. Now we'll go to a case scenario. Is antibiotics the silver bullet, and is it the answer to all queries? We'll discuss a case. A baby X born at 38 weeks of gestation with a birth weight of around 2850 grams. Born through meconium stain amniotic fluid. Cried immediately after birth. Admitted to the SNCU. Has respiratory distress. And the baby started on CPAP. With a PEEP of 5 centimeters and a FiO2 of 90%, maintaining saturations well, 95% in the right upper limb. Temperature is normal. Baby is hemodynamically stable. Now, would you be doing a sepsis screen in this case? First question. Tapasar, is there a way people can respond?
All the participants, please write your response in the chat box.
The second thing is, should the baby be started on antibiotics? And the third thing is, should we keep the baby nil by mouth? So you can answer in the same order. Yes, no, yes, 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 no, 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 something like that.
Please do respond, because then only we
No
will
one will
know
judge. Yeah.
how you understand this topic, because very important topic and it's a
Yeah.
daily problem. If you don't understand, then may not be able to manage the babies properly.
Yeah, and no one is going to judge you. You can always give your answer. It will only reflect on what I have communicated. If you are given a wrong answer, the fault is with me. Okay, we got some answers. Yes, yes, no, 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 yes, no, no, yes. Okay, good. Thanks for responding. I hope more and more of you will respond. Uh, why is this thing not going off? Okay. So there are no maternal risk factors. Baby is settled on very minimal support of CPAP. So you know the cause for respiratory distress. Most likely it is meconium aspiration syndrome. Just monitor the baby for worsening distress. And if the baby worsens, then you consider all the other things, screen and antibiotics and blood culture and all. Otherwise, no role for prophylactic antibiotics in a baby born through meconium stained amniotic fluid. And there are only very few situations where you will keep a baby nil by mouth. So this baby was started on full feeds at 60 ml per kg through a orogastric tube. Okay. So distress, respiratory distress is not a contraindication for feeding, or it is not an indication to start IV fluid. Very common practice. So finally, the baby was weaned off and discharged on day 8. The key take-home message is that not all babies require a septic screen. Antibiotics are not required in all babies, and especially for those babies who are born through meconium stained amniotic fluid and who do not have other risk factors for sepsis. Now coming to case 2, 32 weeks neonate, very preterm, VLBW 1480 grams, born vaginally. 2 doses of steroids were given. Mother had leaking per vaginum for 48 hours and her leukocyte count was 18,800. Baby cried immediately after birth. The respiratory distress score is 4 by 10. Transfer to SNCU, TABC is okay, temperature is fine. Baby was started on CPAP and requiring a PEEP of 6 and effort of 30% and otherwise hemodynamically stable. What should we do next? Should sepsis screen be performed in this baby? We'll see the response. We'll wait for the response. Yes, 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 yes. Good. Yes, 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 yes. Okay. So prematurity or very low birth weight was there. Prolonged rupture of membranes was there. But the other 3 risk factors were not there. But at least 2 risk factors were there. Right? So sepsis screen is to be performed. And these are the results. The screen is negative. What should you do next? Should you start on antibiotics? First question. 32-weeker, less than 1,500 grams, Dopplers are normal, I guess. On respiratory support, non-invasive respiratory support. Should you withhold feeds? Chat box. No S, no S. Okay. Anyone else who wants to respond? S, S. Okay. Okay. So, in this baby, antibiotic was not started. Ideally, 2 screens have to be done. You have to closely monitor the baby for deterioration. If 2 screens were negative, then you can safely rule out sepsis. And baby was started on full oral feeds. Usually, if you see in India, major institutions, they start preterm babies more than or equal to 30 weeks without other risk factors like severe IUGR with Doppler abnormalities, significant Doppler abnormalities, or as a baby with a surgical condition, or a baby with severe perinatal asphyxia. These are or the baby, if the baby is on inotropes or vasopressors. These are the 4 major indications for not starting feeding. Otherwise, most of the institutes start babies on full enteral feeds, irrespective of whether they are mechanically ventilated or whether they are on non-invasive respiratory support. They start full enteral feeds via orogastric tube. For babies who are less than 30 weeks, the protocol vary across institutions. In this baby, KMC was initiated from day 1. So that is very important. There was one of the largest trial that was published in NEJM, which showed that early initiation of KMC decreases the risk factor, decreases the risk of mortality. Mother was counseled for breast milk. Baby received breast milk, complete mother's own milk, complete, not partial, on day 4, and transition to breastfeed on day 10. That is at 33 weeks, and regain birth weight on day 8. Even some of the term babies don't do that. So the learning points are look for maternal risk factors for sepsis in all cases. Do sepsis screen when it is required. But that does not mean that all preterm babies require antibiotics. Okay. Case 3, 31 weeks baby, almost 1,400 grams birth weight. unbooked pregnancy, a single dose of antenatal corticosteroids was given. Cesarean lower segment cesarean section was done in view of antepartum hemorrhage. Mother had fever for 2 days. Leukocyte count is 24,900. Baby did not cry after birth. Admitted to SNCU with a respiratory distress score of 6 by 10. And baby was not hemodynamically stable. Baby required one saline bolus of 10 ml per kg. Now, same. Should screen be performed? Should antibiotics be started? Let me see the answers. Very similar to the previous case, but little different in the sense baby is hemodynamically not stable. Yes, 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 yes. Okay. So many risk factors. So risk factor based approach is not a asymptomatic baby. Okay, it's a symptomatic baby. So the risk factors were there. Now the most important thing is baby was critically ill. It required a saline bolus. So screen was performed. Screen was positive. Baby was started on antibiotics. And remember, culture has to be sent prior to starting antibiotics. Now, how long will you give antibiotics? This is a very, it's an, I mean, I don't think it's the question is complete. So we all discussed this prior. Screen is positive, 5 to 7 days. Try to restrict to 5 days if the baby becomes asymptomatic. Uh, continue till 7 days if the baby is symptomatic, even on day 5. If the blood culture is positive, see the organism, gram positive organism, give for 10 days, gram negative organism, give for 2 weeks. And if meningitis is diagnosed, give for 21 days.
Someone has written 14 days.
Huh?
So someone has written response as 14 days to give antibiotics.
Huh.
So not 14 days, you have a positive sepsis screen, but the culture was negative. And the symptoms are also minimal. So you can safely discontinue antibiotics after 5 days in this case.
Yes. What about feeding? So you can, will you feed this baby or not? Will you initiate feeding, full total and enteral feeding or minimal enteral nutrition and then see? No, okay. No, 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 no. Okay.
So what is the contraindication for feeding? Mahinder,
Answer, contraindication.
for feeding.
At least 4 I told.
If inotrops being used.
Shock. Okay. So this is a dicey question. Okay. So a single NS bolus, and if the baby has improved, then definitely you can start the baby on minimal enteral nutrition and see how the progress is. If the baby ends up with the inotrop, then even MEN, minimal enteral nutrition, you may be justified in stopping that. Okay.
This baby has only required a bolus.
Yes. So in this baby, minimal enteral nutrition was initiated because the shock got reversed after one NS bolus, and the feeds were gradually incremented, and the baby reached full feeds by day 7. Now coming to case 3, baby is being monitored on CPAP for respiratory system, and circulation is being assessed simultaneously. We into the same case only on full feeds on day 6. Okay. Most important points in this case, KMC was initiated a little late on day 3 because the baby was not hemodynamically stable on day 1. So there was a bit of delay, acceptable. Complete mother's own milk by day 6 and transition to breastfeed feeding before even 34 weeks of postmenstrual age and regain birth weight by day 9. So supportive management is important. TABC always assess the airway breathing and circulation and watch out for septic shock. Now, case 4, 37 weeks, baby born at 37 weeks of gestation, SGA baby, 2,200 grams, low birth weight, delivered vaginally, booked pregnancy, brought to hospital on day 5. Baby has respiratory distress with a score of 4 by 10. There is fever, history of fever since last 3 days, which is documented 38.5 degrees Celsius, not accepting feed since last 1 day. Started on CPAP, 5 and 30%. TABC is okay. No, TABC is not okay. Temperature is 35.4. It does not come under cold stress. It is moderate hypothermia. See, I teach many of the post-MD, post-doctorate students. I ask them the definition of hypothermia. And how you classify hypothermia. And most of them give the wrong answer. So what is cold stress? Cold stress is when a baby has a temperature in between 36 to 36.4 measured from the axilla, which closely reflects the core body temperature. Okay, that is cold stress. What is moderate hypothermia? 32 to 36, 35.9 degrees Celsius. And less than 32 is severe hypothermia. Okay, so there is a error here. It is not cold stress. It is moderate hypothermia. And airway and breathing, baby is being managed with CPAP. Circulation is all right. Pulses are well palpable. What should you do next? Should antibiotics be started or not? Should we send sepsis screen or not? Answers. Come on, come on. Yes, yes. Okay. Yes, yes. Next. That's all. Only two response. Two
You're,
response.
you're 39 of you, but only 2 response.
I hope सो तो नहीं रहे हो. I mean mute करके. Okay, good. So screen was sent, culture was taken, X-ray was suggestive of fluffy infiltrates, LP was planned, antibiotics was started. It's a case of late onset sepsis, community acquired sepsis, because baby was not in NICU. It was discharged, came back from home, and CSF was normal. And the screen was positive, as you can say, almost 3 parameters, 1, 2,
All
3.
parameters, 5 components, all positive.
ANC positive नहीं है sir, 2200.
हाँ, 4 components positive.
All 4 are positive. So positive sepsis screen, culture suggestive of Escherichia coli, sensitive to amikacin. What should be the duration of antibiotics? Duration, yes. Someone has answered even before the question was asked. Yeah, good. 14 days, 14, 14, 14. Fine. At least some key take-home messages are gone.
Do you want to perform any other investigation in this case? That's not mentioned.
Yeah, it was mentioned, sir, I think.
Mentioned, huh?
CSF was normal.
It's normal. Okay.
So, yeah, 14 days acceptable. Case 4. What about feeding? Do you keep the baby nil by mouth? Yes, no, yes, no, yes, no, yes, no. Come on, come on, come on. No. Yes. Next one. Yes, no, no, yes. Okay. Okay. Why do you want to keep this baby nil by mouth? Baby did not have perinatal asphyxia. History does not say that baby has septic ileus or any surgical abdomen. Day 5 baby. Uh, so the question of umbilical Doppler does not come, and is a term baby. Of course, it's a small for gestational age baby, but it's a term baby. And baby is hemodynamically stable. So why should you not start feeding? So this baby was started on full OG feeds using mother's own milk and monitored weaned to room air on day 5 and discharged on day 15. So take home message is the same, which I don't want to keep repeating again and again. I hope it has gone into your head. Now, prevention is always better than cure. So in the initial slide, I told you the most important aspect is hand hygiene. If in your NICU, the hand hygiene adherence rate is less than 70%, then whatever intervention you do to prevent sepsis will not work. So hand hygiene is the most important aspect. So you have uh, hand scrubbing and there are two ways of doing hand hygiene using a medicated soap or a soap solution and using isopropyl alcohol or a combination of isopropyl alcohol and chlorhexidine. Next thing, the nursery environment should be kept clean and dry. At least 3 times the housekeeping staff has to do the cleaning work. Ensure round the clock water supply so that doctors can wash their hands. Adequate ventilation, temperature, avoid overcrowding, and during procedures other to strict asepsis protocol, this thing ANTT will come to it later in the next slide, and try to keep interventions to a minimum. In newborn, it is very clear. The lesser you do, the better it is. Okay. And of course, initiate early enteral feeds so that you can decrease the duration or even avoid using parenteral fluids, which itself is a big risk factor for sepsis. So, most important thing I'll stress upon is hand hygiene. Okay. And rest of the things come under the process. Environmental cleanliness, medical equipment processing, healthcare waste management. All the NICU should have a written protocol on these particular aspects. And it should not be only on writing. That should be followed as well. And there should be a designated person who collects data and presents on a monthly basis as a quality indicator. Now, 6 steps of hand hygiene everyone knows, right? So all of you know all these steps, right? But before doing all those things, make sure you don't wear a ring, you don't wear your watch. Make sure if you're wearing full sleeves, it's above the elbow. Don't wear nail polishes. And how much of say isopropyl alcohol you have to take? Can anyone answer? In in mils or in ml or
So,
I'm not asking about the percentage.
mm,
How
that's
much of isopropyl alcohol you have to apply on your hands?
volume.
Yeah, volume.
Must be doing in and out every day.
बस एक प्रेस कर लिया बस most of the times people don't follow the 6 steps. They'll just press and they'll do some Kathakali like thing. Coin sized.
Which coin?
It's okay. 5 to 10 ml. Okay. If you had told 15, I would have agreed because 15 is for surgical scrubbing. They used to take 15. But you can't calculate, right? When you're moving from one baby to the other in the NICU. 5 ml. So there is no particular volume, okay, as to how much you have to take. Roughly 2 presses or 2 presses. And then you do the 6 steps and you have to complete within how many seconds? 20 to 30 seconds, right? So do the 6 steps, okay? Now, before you complete your 6 steps, if your hands become dry, that means that you have taken lesser quantity of alcohol. Not you have not taken alcohol, you have applied lesser quantity of alcohol. Now, that is how you judge. There is no particular ml or anything like that. But a rough rule of thumb is 2 presses. Start your hand hygiene process. Try to finish in 20 to 30 seconds. And by the end of 20 to 30 seconds, your hand should be wet. If it becomes dry within that time period, that means that you have not taken enough. Okay? That is what WHO says. For surgical scrubbing, it is 15 ml. But when you're moving from baby to baby, you can't calculate this many ml, right? So that is one common mistake people do. And the second thing is wait till your hands dry. Of course, it should be wet throughout the procedure, but then the hands have to be dry. Dry. If your hands are wet, then that means that the alcohol is not going to act at all. So that is another common mistake people do. And the third common mistake is you wear a glove, apply alcohol on the glove, and move from baby to baby. What happens when you apply alcohol on a glove? It takes at least 10-15 minutes for the glove to dry. So that means that you would have already touched 4 babies by that time. Right? So never put alcohol on your glove. It will never dry in a quick span of time. These are practical aspects that I am telling you. Now you want to go in depth and read this module from which this picture is taken is freely available in the WHO website. Okay, go through it from one end to the other. You will learn a lot as to what are the constituents of this alcohol scrub you are using, whether the alcohol scrub itself has got a preservative or not, and things like that. And practically how to apply after washing your hands. Should you immediately apply the alcohol? Should you immediately rub your hands with alcohol? So these things you read, go and read. Not all things can be taught. Only the main points I am focusing on here. Okay. And the second part. So people always they have this when an examiner asks, tell me the 6 steps of 5 moments of hand hygiene. The student will say the 6 steps of hand hygiene. Okay, so you have these 6 steps that you have to follow, and you have 5 moments of hand hygiene. When exactly you have to do it. One is when exactly, and one is how to do it. So 5 movements is when you have to do hand hygiene. Okay, very easy. Before touching the patient, after touching the patient, after touching the patient's environment, which could include anything from pulse oximeter to the stethoscope to any of the surroundings. Okay. After coming in contact with any body fluid, for example, urine, stool, respiratory secretions, vomitus, okay, and finally, before any sterile procedure. So these are the 5 movements of hand hygiene as said by WHO. Now I'll ask you one question. Can we do all these 5 steps using alcohol alone? I want to see a yes or no. Question is very clear. There is 5 movements of hand hygiene. Before touching the patient, after touching the patient, after touching the patient's surroundings, before any sterile procedure, and after any body fluid exposure. Now, can we use alcohol alone for all this purpose? No, no. Okay. Only 2 responses. No, S3. Okay. Good. At least 100% strike rate. See, of the 3 of the 5 movements of hand hygiene, there are 2 instances when you have to wash your hands with a medicated soap solution. These are after body fluid exposure and before sterile procedure. Why after body fluid exposure? Alcohol will not act on organic matter, whether it be blood, stool, vomitus, or urine. These are all organic matter. Alcohol will not act on these things. Iodine acts, but alcohol won't. So you have to wash. Medicated soap solutions do act on all this organic infectious material. And once you wash, you come, let your hands dry, and then apply alcohol. Understood? Of the 5 moments of hand hygiene, there are 2 steps where you have to wash your hands with soap solution and then apply alcohol. Okay? And these are very rare scenarios, right? The usual scenarios we see is before touching the patient, after touching the patient, and after touching the patient's surroundings. These 3 scenarios you can apply alcohol alone. Okay? I hope I am clear. If you have any doubts, please put it in the chat box. Now, how to prevent neonatal sepsis? It comes at various time points immediately after birth. What all? Wow, can anyone just write the 6 C's? The WHO says 6 C's. Simple question. Even DM resident can give a wrong answer for the 6 C's. Let me see the chat box. 6 C's, come on. Arey, this is an MBBS question. Clean. I'll start with clean.
Nobody is responding.
This I won't say. This you have to do your homework. If you don't know the 6 C's, talking about other things, I don't think makes any sense. Come on, someone please give an attempt. Google to hai na? You have Google, right? Clean cord, clean clamp, clean surface, clean hand. Yes, towel, clean surface, clean cord, clean cut. Okay, it's a mashup. I think C 6 C's to aa gaya, but it has come in different ways. Okay, but be thorough with all the 6 C's. Clothes also matter. Many of them, I mean, forget to mention that aspect. Okay, so at birth, that is very important. Second thing is skin to skin contact immediately after birth. If the baby has cried immediately after birth. Skin to skin contact does not mean that you put the baby on mother's chest for 5 minutes and you take the baby away to give vitamin K and to weigh the baby's weight. Sorry, my daughter is here. Okay, so skin to skin contacts means at least for 1 hour immediately after birth. Okay. Now the other things, equipment used, it has to be sterilized. This should be in your written protocol, and there should be a person who should be monitoring it. And as I said before, quality indicators should be reflected and be presented in at least monthly. I mean, orogastric tube insertion, IV cannula insertion, IV fluid preparation, or medication preparation of medicines, preparing parenteral nutrition under a laminar flow. There are bundles for CLABSI, that is central line associated bloodstream infection, prevention of CLABSI, intubation, surfactant. There's so many things. All you have to do is make sure that proper aseptic conditions are followed. I'm sorry. Uh, I'm just sorry. My kid is here. She's making a. So bassinet scripts, warmers, incubators, they have to be clean. A very common.
It has been covered in the workshop, first workshop.
Oh yeah.
Just
Yeah,
a
but yeah, a very common thing that we usually see is the OG tube with its cover would be put in the bassinet. Okay, that is an unsterile thing. That cover has traveled through so many routes and have come to your hospital pharmacy, and now you are putting that same thing on the baby's bassinet. So that will contaminate the baby's surroundings. Okay, so keep a watch on all those things. And I don't want to go into the other things because these all will come under your sterilization and this thing, the other aspects. Okay. So just remember, you should have a protocol, written protocol, a quality indicator, and it has to be presented, and you have to see the progress uh, in a monthly duration. CLABSI, I told you there are bundles for CLABSI, there are bundles for preventing ventilator-associated pneumonia, there are bundles for preventing catheter-associated UTI. So there's so many bundles. But every bundle starts with hand hygiene. Please remember that. If that is not done properly, the other aspects of the bundle will not work. Now, coming to aseptic or non-touch technique, or what is it, antiseptic non-touch technique, is very simple. I told you. First thing is hand hygiene. Okay. And don't contaminate the key parts where you are going to insert the central line or the umbilical cord or things like that. Touch non key parts with confidence. Take appropriate infective precautions like draping. Uh, Make sure that you are properly gloved and all those stuff. What I mean, I can only show you the signals because if I keep on talking, this lecture will not get over. Now, as I said, nutrition is very important. Mother's own milk is one of the most important aspects that could help you to prevent in neonatal sepsis or decrease the load of neonatal sepsis in your unit. And the storage of express breast milk and these things will come under other topics, I think. Avoid formula milk. Day one, mothers might produce only a little bit of milk, but that is concentrated colostrum. Okay. In some countries, they start with 40 ml per kg. We start with 60, right? In term, they start with 40 ml per kg with mother's own milk because that is calorie dense. And the other things, I am not going in detail into those. What is this slide about? When to isolate a neonate. Whenever you have outbreaks, Uh, when neonate is known or suspect to be colonized or infected with a different pathogen, and in that aspect, MRSA is notorious. There are units that routinely sample the nasopharyngeal swab for MRSA because MRSA outbreak can be bad. Klebsiella outbreaks, we have seen they can wipe out the NICUs. Okay, in such cases, you have to isolate. You should have an isolation room and make sure the nurses do not come out and talk with the nurses in the other room. That is a very common practice. So these things have to be taken care of. And neonates, particularly at risk of occurring HIA, includes neonates, say, who have SCID, that is severe combined immunodeficiency, neonates who are on corticosteroid therapy, systemic corticosteroid therapy, and so and so. Now, take home messages. I will start with prevention is the key. And I'll move on to hand hygiene is the key. Promote enteral feeding. Okay. And follow antibiotic stewardship. Right. And surveillance and other things. Your hospital system should have a policy and that has to be implemented and monitored. Okay. So prevention is the key. Hand hygiene is the other key. The key component of preventing sepsis, early enteral feeding and avoiding unnecessary antibiotics, and antibiotic stewardship. Stop when it is not required. Okay. And surveillance and other sterilization or decontamination processes. Thank you. Any doubts, you can always put in your chat box.
All the participants, if you have any question, please put in the chat box.
Come on, yeah, you people understood everything. There should be some doubts, right?
So question is there any upper limit of TLC in sepsis screen? So this was already talked about by the speaker that the lower cutoffs are in sepsis, the cutoffs are usually lower and not there's no upper limit of TLC for which you have to for which you can see in babies with sepsis. So it's a lower limit that is being used. So cutoff is less than 5,000 as one of the component of sepsis screen. Any more question?
So everyone is clear about antibiotic stewardship and other things.
How many of you run sepsis screen in your unit before you start antibiotic? And sepsis screen means all the 5 components of sepsis screen. How many of you do?
And how many of you do serial CRP monitoring?
Are you right? Yes or no? Something, bhai? 27 participants, 26. Good evening, Dr. Veera, Dr. Tapas.
Good evening.
Hello, madam.
Yes, no भी नहीं लिख रहे हैं बच्चे. कहाँ गए सारे पीजीज? नाम से बोलते हैं. अन्वेषा, अपर्णा, दिनेश,
Please do this.
आदित्य. Yes or no? Just write yes or no whether you are doing all the components. IT ratio.
IT ratio, micro SR, everything, huh? Somebody is written.
Good. Someone is honest.
No, okay, good.
Mahindra Chaudhary and Dinesh, would you be doing it from now onwards? Or would you at least put an effort to do it in your unit? Mahindra and Dr. Mahindra and Dr. Dinesh. Very good.
Good.
So I mean, at least 3 or 4 of you, please, I just want to know what was the most important take-home message that you got from here, apart from hand hygiene? Of course, that had gone to everyone. At least one take-home message that you think you can implement in your NAC, or you yourself will practice and be a champion and make others practice. 1 point.
1 point from each of one of you.
Anyone? I mean, I'll put it in another way. Very good. Okay. One practice that you used to do, now you won't do it. One practice that you used to do, you won't do it. Early, yeah, very good. Early initiation of feeding. Early feeding, very good. The message has gone, yeah. So you won't be keeping a baby in nilbay just because the baby is on CPAP or respiratory support or ventilator, right? Unless there are the other 4 contraindications. And you won't be doing a serial CRP monitoring, but I'll say 1 after 48 to 70 hours of initiation of antibiotic is justified. But that does not mean that it will be normal. A downgoing trend, if you document it, just leave it just there. That's it. What about KMC? Early initiation of KMC, skin to skin contact for 1 hour, at least 1 hour, at least 1 hour.
It's 1 ml. Someone has written that in collecting blood culture sample, minimum amount of blood collected should be how much? So it is 1 ml, not below 1 ml.
So at least 1 ml. If you inoculate more, the chance of isolating the bacteria will be more, but at least 1 ml. Now
And
the same blood culture Bactec bottle you can use to inoculate CSF and urine also. This is something many people don't know. How many of you have seen CSF culture growing something? Very rarely. So you can use Bactec bottle to inoculate CSF as well as urine, provided you have the resources and the money in your hospital. Any doubts? And remember, while collecting blood culture, one common mistake is residents wait till the blood comes to the hub of the cannula. You have to take you have to draw the blood before it touches the hub. Once it touches the hub, it will be contaminated. You will either the culture will grow cones or some other contaminant. So there is a particular way of taking blood culture as well. I hope these would be taught in the workshops. Any doubts? Any other anything anyone wants to say? I mean, I'm not sure whether you're allowed to talk or.
Yeah, they can unmute and they can talk.
Yeah, please go ahead. Don't be scared. I mean, it's your platform. You have the right to ask questions.
I think the message has gone to them. It's already 9:30.
Yeah.
So, Ria, can you please wind up the session? Ria?
Sure, sure, sir. Am I audible?
Yeah.
Thank you, sir. It was a wonderful and very informative session. Thank you for giving us the opportunity to host the session. We hope to have you again on our platform very soon. Thank you so much. Have a good night, sir.
Thank you. Good night to all.
Thank you. Good night.
Thank you, Veer. Good night.
Thank you, Tapas sir, Pratima ma'am, and others, Soma Das. And all the delegates, please do practice what you. It should not be on the paper alone. You should put it into practice as well. Thank you. Thank you for patiently listening. Bye. Good night.
Thank you.